afternoon and welcome. My name is Erin Bascom and I'm the Senior Associate for Prevention here at the National Alliance of State and Territorial AIDS Directors. So thank you so much for joining us for today's webinar, High Impact Prevention for People Who Inject Drugs. First, I just want to inform everyone that the webinar today will be recorded and it will be made available on NASTAD's website for public access following the webinar. Today's webinar will begin with a brief introduction from NASTAD to set the stage and describe the federal and state level outlook on drug user health programs and share some of NASTAD's work on this topic. Next, Alessandra Ross will discuss the spectrum of drug user health programs that health departments can consider and the opportunities and barriers that health departments face in implementing these programs. Alessandra works as the Injection Drug Use Program Specialist for the California State Office of AIDS, where she coordinates the state's efforts to reduce HIV infection among people who inject drugs. Her current work focuses on addressing policy barriers in order to allow people who inject drugs better access to sterile syringes, as well as to the tools and resources they need to protect and improve their own health. Alessandra has a master's in public health and has been mentored by many dedicated and patient harm reductionists over the years. Our next presenter will be Dominic Zerlo, who will talk about New Mexico's harm reduction and hepatitis surveillance work. And Dominic is the program manager for hepatitis and harm reduction at the New Mexico Department of Health. He's been working in harm reduction for over 15 years and in the field of substance use since 1989. He has a bachelor's in biological anthropology, a master's in educational psychology, and is an advanced doctoral student at the University of New Mexico, also in educational psychology. He focuses on human development and education processes and how they can be applied in the development, implementation, and evaluation of programs with individuals injecting substances. And then finally, we will have time following the presentations for an interactive Q&A session with Alessandra and Dominic. So before our presenters begin, we'd just like to take the opportunity to provide some context on the current national environment around services for people who inject drugs. Numerous federal agencies have taken a stance on drug user health strategies. The National HIV/AIDS Strategy, released by the White House in 2010, outlines the President's vision for reducing HIV incidence, increasing access to care, and reducing HIV-related health disparities. The strategy notes that comprehensive prevention and drug treatment programs, including needle exchanges, have had a tremendous impact in reducing new HIV infections among people who inject drugs since the beginning of the epidemic. Furthermore, they list access to sterile needles as one of the scientifically proven biomedical and behavioral approaches that reduces the probability of HIV transmission. The Department of Health and Human Services released an updated action plan for the prevention, care, and treatment of viral hepatitis in 2014, and this includes a section on reducing viral hepatitis caused by drug use behaviors. And the action plan acknowledges that state, local, and community partners play an essential role in developing and supporting comprehensive viral hepatitis prevention programs for people who inject drugs. It also recommends that, among other things, these programs provide, when possible, access to sterile injection equipment for people who inject drugs who cannot or will not stop injecting drugs. Also in 2014, the Office of National Drug Control Policy issued an updated National Drug Control Strategy in which the administration reinforces that it's committed to informing public health systems on the implementation of needle exchange programs that protect the public, reduce infections, and encourage involvement in substance use disorder treatment. So despite the public health evidence behind syringe exchange programs and federal support for their implementation, there remains a long-standing congressional ban on using federal funds to support the distribution or exchange of sterile needles. And this funding ban has presented a challenge to many health departments trying to implement comprehensive drug user health programs for many years. In fact, results from NASTAD's National HIV Prevention Inventory in 2014 found that health departments listed federal, state, or local policies as some of the biggest barriers to operating a syringe services program in their jurisdiction. Recently, however, there's been some movement in Congress on this funding issue. The draft 2016 House Labor, Health, and Human Services Appropriations Bill includes a new provision that would allow the use of federal funds for elements of a drug user health program other than the actual purchase of needles or syringes if that jurisdiction is experiencing or is at risk for an increase in hepatitis or HIV due to injection drug use. So while the congressional ban on using federal funds for syringes remains, this new language would allow federal funds to be used for services like substance use counseling or treatment referrals in areas experiencing or at risk for outbreaks of HIV or hepatitis. And as many of you are probably aware, there is some state-level context that may be prompting some of these shifts. Earlier this year, a small county in Indiana reported an HIV outbreak. Over 130 new infections were reported in Scott County, Indiana, with the primary mode of transmission being injection of an opioid called Opana. And this outbreak occurred in a rural, high-poverty area of the state with high rates of drug use but historically low HIV incidence. Also of note, over 80% of these newly diagnosed individuals also tested positive for hepatitis C. So this speaks to the importance of integrating hepatitis and HIV prevention and treatment services for populations of people who inject drugs. And this outbreak has prompted legislative action in Indiana. The Governor Mike Pence signed an executive order in March 2015 that declared a public health emergency and allowed for a targeted short-term syringe exchange program. And then in April, the Indiana House and Senate passed a new bill which was signed by the governor this May, which would allow a local health department or a municipality to operate a syringe exchange program if there's a documented epidemic of hepatitis C or HIV where the primary mode of transmission is through intravenous drug use. Also this year, the Kentucky General Assembly passed a bill signed by the governor in March which amended their state statute to allow local health departments to operate syringe exchange outreach programs. And this law also included a Good Samaritan provision, which provides certain legal immunities to those seeking medical assistance for themselves or others due to a drug overdose. Several other states, including North Carolina and Georgia, have also recently enacted Good Samaritan laws in their jurisdictions. And NASTAD, in its commitment to drug user health, will continue to monitor these developments, along with offering continued technical assistance to health departments to address the needs of people who inject drugs. And to give an overview of some of our recent and upcoming work, I will turn it over to Natalie Cramer, NASTAD's Senior Director for the Prevention and Care Program and Policy, to share some of NASTAD's work on this topic.
Great, thanks, Erin. So I just wanted to say a word or two about NASTAD's ever-expanding drug user health portfolio. So as some of you know, we were fortunate enough to receive some resources from the MAC AIDS Fund in 2014 to support drug user health initiatives. And with those resources, we pulled together a technical assistance meeting with 13 jurisdictions. And then following that meeting, the information that was generated there, as well as through other conversations that we had over the year, NASTAD released a document in April of 2005 entitled Maximizing Health, Minimizing Harm, the Role of Public Health Programs in Drug User Health. And if you haven't had a chance to take a look at this, we strongly encourage you to do so. It is on the NASTAD website. But this document highlights a couple of different areas of really innovative work that health departments are doing around HIV and HCV prevention, HIV and HCV treatment, mental health and substance use treatment, overdose prevention, and then collaboration and relationship building, all to support drug user health. Each section has recommendations that are specific for what health departments can do, and then it closes with a final section that includes recommendations for federal partners, for policymakers, as well as for people who have ever injected drugs. Also, this fall, we will be releasing a white paper with resources from the Elton John AIDS Foundation. We have an initiative on modernizing public health law and policy opportunities under the Affordable Care Act for drug user health. So we are in gathering information from a handful of jurisdictions around opportunities under the ACA, including Medicaid, as well as private insurance for expanding coverage for activities related to drug user health. And this is somewhat uncharted territory, but we are really excited to be at the forefront of gathering some of this information and expect to put this white paper out sometime in the fall. And then we are also pleased that we have been funded for a second year of funding from the MAC AIDS Fund, and with those resources, they will be supporting our NASDAQ's first ever Beth Weinstein Drug User Health Fellow. Beth was one of our founding NASDAQ members. She was from Connecticut and was a longtime advocate for drug user health activities. So we will have a full-time staff person that will really expand our capacity and our reach to support health departments with their local efforts as well as national efforts in this arena as well. So I just want to say a couple words about some conversations we had at NASDAQ's annual meeting, which took place in May. Obviously, in light of the HIV and HCV outbreak in Indiana, drug user health activities were really at the forefront of our members' minds. And so we were able to do 2 sessions there where we had Andrea Perez, the AIDS director in Indiana, as well as Beth Meyerson from the Rural Center for HIV/AIDS Prevention, talk a bit about what's happened there. But we really framed these around the readiness of other health departments to respond or to prevent a similar outbreak. And then following that, there was sort of strong support from the membership that NASDAQ needed to revisit the Statement of Commitment, which was developed in 2011 around promoting drug user health. And to that end, we are poised probably next week or the week following to release an updated statement. This is going to be a statement of urgency around addressing the opioid epidemic in the United States that includes 11 different programmatic and policy recommendations and actions that we are encouraging all health departments to adopt. So be on the lookout for that. Back to you.
Great, thank you. Thanks, Natalie. So with all of that in mind, the objectives of today's webinar are to provide an overview of integrating viral hepatitis prevention, overdose prevention, and treatment services into HIV prevention programming, and describe why this is relevant for, or why prevention programs for people who inject drugs are relevant. And then we're also going to describe examples of health department programming and partnerships that provide effective, high-impact prevention for people who inject drugs. So with that, I will turn it over to Alessandra to begin her presentation. And you can press *7 to unmute your line, Alessandra.
All right, thanks, Erin. I appreciate it, and thanks, Natalie, too. I'm really happy to be here. The topic is fantastic. Dominic is going to give a really good example of what an integrated approach to drug user health can be from a State Department perspective. And I'm going to talk a little bit about smaller things that health departments that are more restricted can do to build up to that kind of comprehensive approach, and also talk about what some of the barriers are when we start to do this work. So most health departments that are doing HIV prevention in the U.S. now are going to be concentrating on gay men and other men who have sex with men, particularly African Americans and Latinos, and that's a really key part of high-impact HIV prevention. But hopefully most of those same health departments are going to dedicate at least a small amount of resources also to HIV prevention for people who inject drugs, especially given what has happened in Indiana. And so the drug user health perspective can really help us use those resources to maximum impact. For people who work in HIV, the drug user health approach means thinking beyond HIV prevention to include hepatitis C and opiate overdose prevention and response. And the model also really encourages us to look at the whole person, like what all do they really need, rather than focusing exclusively on what we're funded to give them. So drug user health is a difficult concept for people to grasp. It's a really difficult one to explain. I'm sure most of us on the phone right now have tried to explain either harm reduction or drug user health to a colleague and had the colleague say, wait, drug user health, isn't that a contradiction in terms? And we probably all have, standard responses that we use in that circumstance. I tend to say, yeah, it kind of sounds like a contradiction in terms, but I don't think it has to be. And that often leads us to a more interesting conversation than the one we were headed for. The other thing that I try to make really clear to people that are new to this work and are perhaps feeling unsure about it or unsteady is that I do try to make it really clear that most of my work is in support of people who are going to continue to use drugs. And that, in fact, a lot of those people are really committed and passionate about continuing to use drugs. And the reason why I try to make that so clear is that sometimes people who are familiar with other approaches are thinking, why aren't you trying to stop people from using drugs? Where does that part come in? And if I explain that there are people who do that for a living and who are really committed to it, and that there are also people who use drugs who really want to stop, sometimes those two are a good match for one another. But that what I'm doing is working with the other people, the ones who don't want to stop or feel that they can't, and making sure that they have that same support, that they also deserve to have support for protecting their own health and improving their own health. So that seems to work pretty well. So the answer to this question, what can health departments do to address drug user health, is going to be different for every health department, right? What works in California is not going to necessarily look attractive to people in Alabama. They're not going to say, oh, yes, we're so similar to you in California. But we all do operate under a variety of different restrictions, funding, political climate, size. We do, though, have some things in common. We all do some kind of programmatic work. Either we do it ourselves or we pay other people to do it. We do some kind of policy work, which could be legislative analysis, but it also could just be as simple as deciding what to fund and deciding what the rules are for our grantees. We do some kind of data collection and analysis, and we package that up with beautiful charts, and we give it to someone for some purpose. And then we all do have some kind of leadership role. If the state health director says that something is a problem, people tend to accept that, yes, it is a problem. And if he or she suggests a solution, that tends to have a lot of influence on how the problem is framed and what the solution is thought to be. So what I would say that health departments can do is we can do what we've always done, and we can frame what we're about to do as an extension of the work that we've already done, as similar to what we're currently doing, as an important adjunct to our current plan. Those kinds of things help make people much more comfortable when we're doing new program or new policy. That's one of the reasons why pilots are so popular, because they're a very safe way for a health department to take a risk. But there's other things besides pilots that health departments can be very comfortable doing. And just an example, in California, about 8 or 9 years ago, we were recruiting for new members for our planning group, our statewide planning group. And for the first time, we really put a lot of energy into recruiting people with lived experience, people who had injected drugs, people who are currently injecting drugs, people who served those people who were researchers and had that expertise. So we really focused on that, and we got a very different group of advisors from that effort. It wasn't a controversial effort because it was very much in keeping in what we'd done before, but it made some different results. Other examples, the health officer for Rhode Island sent out a best practices memo several years ago suggesting that physicians should prescribe syringes for their patients that used injection drugs. And that was just in keeping with the kind of work he had previously done about best practices. In California, our health officer issued a letter talking about co-prescribing naloxone along with prescription opiates. And that was not a big leap and not a big change, but could potentially have a big impact. So I want to look a little bit just at the research part, the gathering evidence, and this is from NASTAD's publication that they were talking about, the Maximizing Health, which is just great, and it's got so many good ideas. So I really recommend that you take a look at it. But in Wisconsin, they pulled together a bunch of data about hepatitis, about overdose, about heroin, and they used that to help the legislature make the changes that they did there. So it's worthwhile just thinking a little bit about what kind of evidence, and hopefully we'll all be called upon to gather this evidence. The two pieces that I like to focus on are evidence for how we have defined the problem, and then evidence for what we think the solution is. So just an example of this, I was working with a group of colleagues on opiate overdose response from the state level, and one of the suggestions was let's try to go as upstream as we possibly can on this. And the person who was suggesting that said, so that means that we need to prevent drug abuse. But then when we looked at what the data was, who was overdosing, who was dying of overdose, there was a whole bunch of different reasons and a whole bunch of different kinds of people who were affected by this. And so when we brought in that data, then it became clear that we were going to need to redefine the problem. And one of the problems that we ended up really focusing on is let's focus on overdose death and preventing overdose death. And that meant that we would look at naloxone and making sure that naloxone gets into the hands of people who can use it right away, such as drug users and their families and friends. So that's an example of where data really did make a difference. It swayed everyone in the room to say, oh, okay, yeah, let's think about this differently. But anyone who has worked in needle exchange knows that the data is necessary, but it is not sufficient. It is, we have so many decades of research. We have consensus about syringe exchange being effective HIV prevention, but it's not enough to sway some people. So there's a few other things that we can add into that. One is sort of the everybody's doing it argument, which actually can be really effective, especially if you're talking to a state health department or to a state legislature about what other states are doing. One of the things that I learned the hard way is that our state is not interested in what Massachusetts is doing, even though they're doing some really cool stuff, because Massachusetts is too small to be a good comparison. So that made me go, okay, I'm just going to look at New York, and I get it. Another thing that can have some real impact on people is looking at who's made these recommendations, and that's one of the reasons why this work that NASTAD does can be so valuable. Here are the recommendations. What we found is that it's great that the American Pediatric Association has endorsed syringe exchange as effective HIV prevention, but it's even better that the California Pediatric Association made that same endorsement. So one of the things that is so impressive about what's been happening lately is there's been legislative action, and that brings new opportunities to health departments. But sometimes there is no legislative support. Sometimes there's it can feel like there's nothing we can do. So one of the things that we can do is just look around within our own domains and see if there's policy and program that we can change without that legislative support. And an example of that is that in California we did a really thorough examination of SAMHSA's SAPD block grant funds. And for those of you that aren't familiar with them, they're this is Substance Abuse Prevention and Treatment Funds. And in states with high HIV prevalence, they're required to spend 5% of that money on early intervention services for people with HIV or at risk of HIV. And what we found is that one of the things permitted in the legislation is outreach to out-of-treatment injection drug users. And who does that? Syringe exchange programs do. So that was a place where we could bring two funding streams together, the drug treatment and the harm reduction, and federal funds aren't going to pay for the actual needle exchange, but they can pay for that outreach. And so that was a nice thing to be able to find and do, and some programs have been able to take advantage of that. The other thing that we've done is really focus recently on non-prescription syringe sale through pharmacy, which is often less controversial than syringe exchange and provides more access to sterile syringes. And most states do have laws that will allow them to do this. It can be a little delicate, it can be a little tricky, and a great resource for that and to figure out what the nuances are is Law Atlas, which if you just Google it, you'll find it. It's got great resources and all kinds of state laws related to public health and harm reduction. So all this persuading can feel kind of discouraging at times, or persuading or educating or however we want to think of it. But I try to think of it as support for all of my millions of bosses, and seeing how I can support them in making a decision that will really feel good for them and work well for public health. One of the lessons that I've learned from lobbyists who work on overdose issues is that when they go to visit legislators, they always bring a researcher and a mom. So the researcher gives the facts, and the mom tells the heart of the story. What happened to her son or daughter? How has that changed her life, and what does she want to change because of that? And so I try to remember to have my own story and to bring that in when I get tired of facts for a moment and other strategies. So this is my contact information. Our website there has a lot of resources, particularly about non-prescription syringe sale, which is what I'm really focusing on right now, and working with ADAP pharmacies to get them to understand the HIV prevention piece that they can provide. And the other thing that's on that slide, of course, is my thank you to all my colleagues that do similar work and really innovative and creative things. So I will pass the baton over to my colleague, Dominic Zerlo, and thank you for this opportunity.
Great. Thank you, Alessandra. And Dominic, before you get started, I just want to give a quick reminder that if any of our audience members have questions, you can submit those via the chat box on your screen, and we will address those at the end of Dominic's presentation. So Dominic, if you just want to press *7 to unmute your line.
Okay, so thank you, Erin and Natalie and NASDAD for inviting me here, and Alessandra, thank you so much for that great first presentation. Really covered a lot of groundwork, and I think you will all find that some of what I'm going to be presenting on really helps to illustrate what Alessandra was talking about. So the first thing is, whenever we're looking at harm reduction programs and really looking at how to design them, we really need to figure out what the needs actually are. And so doing a survey and a needs assessment is very important to it. That's really what's going to allow us to be able to design a plan to be able to meet the needs and to be able to really target our prevention and treatment and other services to those individuals who need it and who are most likely going to be ready to receive it. And then we actually try to implement the services and education programs, and of course the next step is to evaluate them. Are we actually doing what we wanted to do? Are we accomplishing what we set out to achieve? And then of course making modifications to these services. And then as one of my colleagues says, it's the rinse and repeat step, but basically go back and start to repeat all of these steps and really to continue doing this on a regular basis. It can be about small portions of the program, or it can actually be the program overall. One of the things that sometimes I think is very important to remember is we're dealing with issues that are so much larger than we are. And while we may sometimes seem like that tiny drop in a lake, we have that ripple effect, and we're able to cause a lot of good results to occur, but we have to try to remember that not to be overwhelmed by the rest of the lake. So basically remembering that, even though it may seem like a small action is not consequential, it actually has a lot of consequences, especially down the road. And one of the reasons I want to share that is because I actually just got a text right before this started from one of our contract providers letting me know that they actually were able to reverse an overdose at a shelter just this afternoon. And so that person has now received not only their own building of self-worth, but they are so excited that they've actually been able to have an impact on someone and been able to reverse an overdose. And we see that on a regular basis, and we have to take those stories, like Alessandra was saying, those personal stories, and make sure we're relaying that as well as all of the evidence. So in New Mexico, we really look at the beginnings of harm reduction as far as from an empirical basis from a seroprevalence study that was done between 1993 to 1997. But before that had even happened, there had already been underground exchanges occurring here in New Mexico. And it was because of some of those and because of some of the various doctors and other staff at the Department of Health that started to push for that, that this seroprevalence study really was able to occur. And while there were several thousand individuals in the study as a whole, there were 1,003 individuals who were injecting substances. And the seroprevalence rates on it were fairly high as far as for hepatitis B at 61% and very high for hepatitis C at 82%, but also ended up being very low with regard to HIV at less than 0.5%. And so this was very important because as the legislature started considering our Harm Reduction Act, one of the things that was really focused on was the hepatitis C rate and really ensuring that here in New Mexico especially that we address hepatitis C as well as HIV. And so one of the things that we talk about a lot here in New Mexico is really the integration of the programs. And so while the program itself originally started out as a part of the HIV prevention program, we've always integrated services along with hepatitis C and keeping hepatitis C always in the forefront of what we're doing. And so our legislation in New Mexico was passed in 1997, and we actually implemented the program in 1998. And there was support in the areas of legislation, policy, and advocacy. And one of the things that's been very helpful in New Mexico is we have had state funding since the beginning of the program. And so to us, it's not a lot of funding, but for many other locations in the country, it's actually a lot of funding. And I'll talk a little bit more about that in a bit. The program overall conducts about over 40,000 exchanges per year at this point, and that's over 4 million syringes. Now, in some of the large cities, that may seem like 4 million syringes isn't a lot, but you have to take into account how large New Mexico is geographically. We're over 400 miles north to south and just over 300 miles east to west. And there's only 2 million people in the entire state. So what this really says is that we're exchanging 2 syringes per person that live in the state every year. And one of the nice things about our program, because of the access that we actually do have around the state, we're able to collect between 94 to 96% of the syringes that we distribute. This part is very important because especially when we're working with local communities, we're able to talk about our collection rates in order to talk about how we're making the community safer, not just the individuals who are injecting substances, but also everybody in the community, so that we're not finding as many syringes on playgrounds, in alleys, on the street, in parks, and we're really able to utilize that when we do have people who come up and lodge complaints about finding a syringe or having a syringe or accidental needle sticks that happen in public spaces. So throughout the state, we actually have over 40 different locations that are able to provide syringe exchange and related services. The majority of these are operated by our Department of Health, and we have a statewide Department of Health. We also have 9 additional contract providers who provide syringe services, and then 3 contractors who also provide hepatitis surveillance and support. We have an additional contractor who focuses on AccuDetox treatment, and another contractor who focuses specifically on helping us to work with law enforcement and other trainings. And of course, we're continually developing other community locations as the years go by. Some of the things that our programs offer is we offer overdose prevention as an integrated part of our syringe services, and we actually have developed a training on this. Our original training was a 3-hour training, and I'll talk a little more about that, but we've made it so that it's now a 15-minute training where we can deliver it on the street with people quite easily, even in poor weather or hot weather, as we get quite often here. We're able to do this in about 15 to 20 minutes to be able to get people in the lock zone and for them to be able to then know enough to be able to utilize it and have access to it. We continually are looking at where we need to expand our services and which populations we need to start engaging. And so we started a few years ago offering safer smoking kits. And what's interesting about that is even in our different locations, as we educate people in our offices and with our contract providers, they'll often have the mouthpieces and the chorboy that we do offer, but because they don't have it displayed, participants coming in have no idea it's even available, and so they don't ask about it. And as soon as we say, well, put it out on the table, just have it showing there, suddenly they start having people asking them if they have chorboy, if they have mouthpieces. And so sometimes it's also getting that information out to people. And we really look at things from a broad view of infectious diseases. So we don't just look at HIV and hepatitis. We also look at things such as wound care, nutrition, sleeping patterns and behaviors. Has somebody been out sleeping on the street for the last several nights, and so that their immune system may be down, they may not be feeling very well? Have they been woken up by the police multiple times over the last several nights? And then we also, whenever possible, try to integrate treatment and behavioral health services. So we have several locations which actually have Suboxone programs on site or who have close relationships to be able to refer people to Suboxone programs. We have locations which offer AccuDetox, both on demand and during scheduled hours. And then we ensure that our counseling, testing, and referral services are integrated, not just with syringe exchange, but also with regard to HIV and HCV prevention efforts. Some of the additional services that our contractors offer include HIV, HCV, and STD counseling and testing, adult viral hepatitis vaccination, testing and surveillance, wound and abscess care, health care, food bags, clean water, which sometimes, especially in some of our communities, can be very difficult to obtain. And I've talked about some of the others, but one of the other things that has been really important with our program here is we recognized early on that with our large geography and our spread out population that we needed to have an infrastructure to really be able to ensure that our training was standardized. So what we started to do is in about 2007, we developed and implemented a standardized harm reduction certification training program. We'd had trainings in the past and before this, but they'd often been done by different individuals within different regions. And by standardizing it, one of the things that we were able to do is ensure that regardless of what program a participant went to, they were going to get the same information and same kind of treatment at all the different programs. So one of the things that we do with this is we ensure that we have 2 trainers who conduct the class, and it's an 8-hour all-day class. We have about 4 hours of harm reduction history, philosophy, safer injection techniques, including demonstrations and role plays. And then we do 4 hours of overdose prevention, which includes rescue breathing and naloxone administration. We do have several prerequisites that over the years we've learned people coming into this training were asking us basic questions about HCV and HIV, bloodborne pathogens, HIPAA, and so we do have a few prerequisites that are through online courses that we do offer, or that we have borrowed from other free places. And so we do make sure that people go through and arrive at the class with at least a basic understanding of some of these other issues. We offer this training freely to anybody who's conducting harm reduction activities, and not just in New Mexico. And here in New Mexico, one of our regulations is that anytime harm reduction is occurring, there has to be at least one certified individual present. And we do recommend that all the individuals present be trained, but we also realize that sometimes there may be volunteers or new staff, and we don't want to stop them starting to learn about the process. One of the other things to ensure that we keep up with people having the latest information is that we do require that the training is necessary to be repeated every 2 years. Several years back, we had many locations that were still offering or suggesting using bleach to clean out our syringes, and that's one thing that we don't actually offer anymore, and so we had to actually go through a process and retrain everybody to ensure that they knew no longer to be offering that particular service or those supplies to participants coming in the program. So as we continue to grow the program, and right now we have several hundred people who are actually trained as harm reduction specialists. And so while initially we had one trainer and then started to expand that a little bit, we realized our next step in our growth was actually to develop a training of the trainer. And so we did that in 2009. And our first class, we had 9 trainers who ended up being certified. And initially our requirements for it was simply, are you interested in being a trainer? Well, we kind of learned that we needed a little bit more than that. And so now we actually have a few additional training requirements, which includes that the individuals going through this have to have 2 years of direct harm reduction experience. They have to commit to us. If we're going to invest in doing the training, they have to commit to us to conduct at least 3 trainings a year. And they have to be approved by the harm reduction program manager. And then again, they also have to do the prerequisites. And after they finish the 3-day training, they also have to conduct an observed training. And now currently we have, because of course some people have moved on to other positions or moved, we now currently have 25 active trainers in the state, and we're about to do our next training of the trainer the first week of August. So one of the things that we really want to make sure that we do during all of our trainings is integrate not only adult viral hepatitis and harm reduction, but also ensure that we have counseling and testing for HIV and for other STDs included in this. And so we really encourage all of our harm reduction specialists to take our CTRS, counseling, testing, and referral service training as well, and also to become familiar with our STD testing protocols and procedures. One of the things that we also do to help encourage people to attend the trainings is through our AETC, the AIDS Education Training Center, we're able to offer CEUs and CMEs for both trainings. For the 1-day training, we are able to offer 6.5 hours, and for the 3-day trainings, we're able to offer 19.5 hours. And those are offered free of charge to anybody who participates in the training. Now, I mentioned earlier about our naloxone and overdose prevention training, and this program started in 2001, and I am very proud to be able to say that New Mexico was the first state to actually authorize and allow for naloxone administration to be legalized on individuals who were not prescribed naloxone. And so since then, we've had a lot of time to work on this program, and it's meant we've also encountered a fair number of mistakes and problems. So originally we had a 3-hour training, and some of the issues we ran into with that was, first of all, the class size would be very small. We'd be able to train 4 to 6 people, sometimes 8, and participants would fall asleep over the 3-hour period, or if we took a break, which we would do, and I can say this very anecdotally. One of the things that that would often happen was that we actually were giving a practical demonstration on how naloxone was being used on some of the participants in the class after break. I myself, at least 2 different occasions while teaching that particular class, had individuals who would come back from break and end up overdosing partway through the second half of the class. And then the other part of it is we were working with individuals who were using at that time. And so quite often, the amount of information we were giving them in a 3-hour class was just too much for them. They were experiencing cognitive overload. Think about just how much information we've presented here today and how much are you going to absorb. Magnify that by somebody who may be using, who may be tired by living out on the streets, and we just had, quite frankly, too much information. So in 2005 and 2006, we realized that some of these things just weren't working, and we started to implement a short 15 to 20-minute curriculum on the street. We went back and forth with how much information to include, how much shouldn't we include. We made sure that it had all the basic information, that it wasn't overwhelming, and we redesigned handouts to make sure that they were easier and simpler for people to read. The other thing that we found with this is before we were only training maybe at most a couple hundred people a year. As soon as we switched over to this 15 to 20-minute program, we were able to start training many more individuals throughout the state. It was easy to integrate this service into clinics that often were understaffed and staff felt they were overworked, and we were able to implement it much more easily in street outreach. And so now at this point in time, we're training a couple of thousand people every year on this. So with regard to HCV surveillance, we actually started a special project in 2014 which we call Under 30, and we're specifically doing surveillance with individuals who are under the age of 30 who have tested positive for HCV. And originally we had 2 contractors who were hired to do surveillance and surveillance support, and that those staff were also cross-trained in harm reduction and HIV prevention. Now, thankfully, we've been able, starting tomorrow, to increase this by a 3rd contractor to help conduct surveillance. What we've really found with this is as the surveyors contact those individuals with positive lab results for HCV, they're able to actually act as a referral and education source for those individuals in addition to just collecting surveillance demographics and information. So if someone starts talking with them about their substance use or injection use, they're often able to give them referrals into other programs and into syringe exchange and harm reduction locations. They're also able to ensure that individuals that they contact have the necessary information for their next steps. Quite often they're finding that their doctors are not actually giving them the information about what their next steps are as far as with regard to treatment, potentially other testing, and support groups that may be available for them. And so what this has really been able to help is it's really been able to integrate some of the things we've been doing in the other areas of harm reduction to be able to ensure that people at least under the age of 30 who test positive for HCV have those additional resources available to them. And I have to admit, this is a fantastic quote, and it's one that I really need to thank Dr. John Ward for saying, and it's the most successful needle exchanges also offer counseling, disease testing, and referrals to places where patients can get treatment. And it's something that we really try to integrate into all of our programs, whether it be within our health offices, with one of our contractors, in an outreach that's in the middle of the desert or in the middle of the mountains. We try to make sure that we're able to offer as much as we can without actually stretching the staff that are there. And when they notice other needs are present, they really try to see what can be done to be able to help with those other needs, which may be food bags, it may be helping to obtain driver's licenses or IDs. We had a situation several years ago where many of the shelters started to require that individuals had to have a picture ID to be able to stay for the night. So one of our programs started helping individuals who are on the street to be able to get picture IDs and obtaining birth certificates and all of those. So we don't look at this as just exchanging syringes for individuals. While that is one of our main missions and our main processes to help people, we really look at this as how do we help treat people overall, and looking at it from a more holistic approach. And again, as Alessandra had said, this may not be an approach that works everywhere, but it's one that we found works fairly well here in New Mexico, and we're able to garner a lot of support for it because we're not focused on just one specific area. We're able to integrate and be able to use resources from across the board and really be able to collaborate with so many different agencies and different organizations throughout the state that we really make sure that they have ownership in what's occurring. And so I'd like to thank you all again. And again, as Alessandra said, I have several thank yous on here for some of our staff at the Department of Health for their help and support. I especially want to thank Blaine Snow, Josh Swatek and Ray Aragon, and John Murphy and Andrew Gans. Without them, we couldn't be doing nearly as much as we do here in the state. So thank you.
Great. Well, thank you so much to Alessandra and Dominic for sharing your expertise and your work with us today. This brings us to the end of the presentation, so we have the remainder of the time to open up the lines for questions. We have a couple of questions that have come in over the chat, so I can start with those. So Dominic, we had a question about your surveillance contractors. Do they meet with people in person or over the phone or both?
So the contractors actually meet with individuals over the phone, mostly because, again, with our large geographic area, the contractors are based two in Santa Fe, and the new one will actually be based in Albuquerque. And so from a traveling perspective, it just is too much of a drain on resources to have them go and do field visits. But if they are absolutely necessary, then we do have individuals who can indeed do that from our regions, our health educators and DISs, disease intervention specialists.
Great, thank you. So if anyone has a question to ask over the phone, you can press *7 to unmute yourself. And please first identify who you are and let us know which presenter you're addressing your question to. Do we have any questions over the phone?
Erin, this is Dominic. There's someone who did ask if I can share our training curricula and materials. And yes, we do. We can provide them to individuals. We've shared them quite often and freely. And so all anybody needs to do is contact me, and then I can make sure to get it to them. There are just so many in such a large file. We're trying to get them up on the web, but haven't been able to do that just yet.
Great, thank you. We do have another chat question. This one's for Alessandra. Can you talk more about the work you said you were doing with ADAP in California? Specifically, the question is to clarify if you said that syringes could be provided via ADAP.
Well, I don't know if there are any ADAPs that actually have syringes on their formulary. That's kind of an interesting question. But what we're trying to do is work with pharmacists to package a bunch of services as HIV prevention and ask that ADAP pharmacies consider also providing these same services, because there are pharmacies that won't even sell condoms. So starting to think about it more globally. So one of the things that we're doing, we have a new request for applications out to get a pharmacy benefit manager, and we're adding into that new, we'll add into that new contract that they'll have to collect information from all of our ADAP pharmacies about whether or not they offer PrEP, whether or not they sell condoms, whether or not they sell syringes without a prescription, do they stock buprenorphine, do they stock naloxone, and just make it into an entire package, and that they would have that information in a searchable database. Because one of the big challenges in California is that there are some places where there are a lot of pharmacies selling syringes without a prescription, but there's lots of places where there is someone, but nobody knows where that pharmacy is. So finding out how to gather all that information about the 7,000 pharmacies has been hard, and this will be a way of getting that information and getting it out.
Great, thank you. We got a comment in from Arizona. Apparently the Arizona ADAP covers syringes and needles if the client has a prescription.
Excellent. Does Arizona include naloxone on their formulary?
That's a good question. Would you care to chime in? You can press *7 to unmute your line if you'd like to comment. Or if anybody else has a question, you can also press *7 to unmute. All right, it sounds like we don't have any other questions. So I'm going to go ahead and wrap us up. If you have any further questions for NASTAD, you can feel free to contact me. Sorry, did we have a last-minute question?
Yeah, I wanted to ask, this is Randy Mayer from Iowa. I just wanted to ask Dominic a little bit more about what they were, when they're contacting people, what kind of information are they getting? Is it mostly about referral to treatment, or what information are they lacking in their surveillance program that they need to go to people to do an interview, or are they mostly trying to get risk factors, or what kinds of things?
Hi, Randy. They actually are doing demographics and doing risk factors. Really what happens is this is the surveillance that's happening here in the state right now with regard to HCV. And so what they're really just getting are essentially the lab slips, maybe a little bit more information. And so they're contacting them to do full surveillance interviews. So it's including demographics, risk factors, if they know. And unfortunately, there's where when they're calling individuals that those individuals haven't even received their test results. And so our staff are trained to be able to handle that and to be able to work with them in a very safe and caring and compassionate manner.
What proportion of people do they actually find on the phone?
I'd have to go back and look at the data, but it's a fairly large amount. We're able to contact quite a few, and our surveyors have gotten very good at tracking people down.
Okay.
If you like, I can get you. If you want to email me, I can get you directly in contact with them, and they could probably help with any technical assistance.
Okay. Thanks.
Great, thank you. And we got another comment from Arizona. Naloxone is not on the ADAP formulary.
I think Michigan was working on that. I think a big benefit here in California is that naloxone is on the Medi-Cal formulary, Medicaid, and that has potential to have a big impact.
Great. Well, I think that's the end of the questions. So I will go ahead and wrap us up. My email address is on the screen now if you have any questions. And again, a recording of this webinar will be available on NASTAD's website shortly. And when the webinar finishes, there will be a brief survey that's going to pop up. So please take the time to provide your comments and suggestions to help us improve future webinars. So thank you again to Alessandra and Dominic. We're so glad that you could join us today. And I hope that everyone has a great afternoon.